I'm Dr. Susanna Banerjee. I'm a consultant medical oncologist at the Royal Marsden Hospital in London. I work at the Chelsea branch and the Sutton branch, and I'm also honorary faculty, so a senior lecturer at the Institute of Cancer Research. I want to start by saying thank you Ovacome, for inviting me. I really admire and respect this charity. I know all the good work that you do and how you've supported many of my patients over the years and currently, and I see some familiar faces in the audience of patients who are currently under my care. So thank you. I have some slides. They're really prompts for me to talk about some of the current standards of treatment and also some trials. But really, after I've spoken to you about what's going on in ovarian cancer and what we do in terms of research at the Royal Marsden and nationally and internationally, it's over to you to ask me questions, and I hope I can answer them. So thank you very much. So I don't need to tell this audience, you know that there's an urgent, unmet need in improving outcomes for women with ovarian cancer. I'm just conscious of the fact that if I look over here, because my eyesight's deteriorated over the last couple of years, I hope you can still hear me with the microphone. But ovarian cancer remains the highest cause, unfortunately, of death amongst gynecological malignancies. In the UK, as you know, there are far too many women passing away from this disease, over 4,000 deaths a year, and over 50% pass away within 5 years of diagnosis. The issue is, or one of the issues, that the majority of women are diagnosed at advanced stages. And to date, we don't have a good enough screening test to identify women early with this disease. Despite high responses to some of the chemotherapy drugs that we have and new treatments, at some point the majority of women's disease will develop recurrence. And recurrent ovarian cancer to date is rarely cured. And I say ... so far because I see women even in this audience who have had recurrent disease, who are living many years and living good lives fighting this disease. So, and I truly believe with the overwhelming new treatments that have occurred, and I'll show you in the last 4 or 5 years, and even in the last few months, that we can achieve that we can achieve long-term survival, even in recurrent disease. Of course, what we want to do is prevent this disease, and that's the ultimate aim. So the typical course of patients to date diagnosed with advanced ovarian cancer is first-line treatment. When I say advanced, I mean stage 3 or stage 4. And treatment consists of a combination, usually, of surgery and chemotherapy, whether that be surgery first, or chemotherapy first and then surgery sandwiched in. I appreciate you're going to have a talk later on by Christina, so I'm sure you'll hear a lot more about surgery then. And then about 7 years ago, when I first started as a consultant at the Royal Marsden, Bevacizumab or Avastin came on the scene, which was a real breakthrough for women with ovarian cancer and treatments. It was actually the first targeted therapy to be approved for women with ovarian cancer. I'm just going to pause a little bit there because I know many of you may not know me or know much about me, but I did all my training at the Royal Marsden. I wasn't going down the oncology route, actually. I was going down the cardiology route. And then as part of my rotation, I did a cancer job, and I knew within 3 days that my whole career was going to change, and I saw this as a vocation. I wanted to do as much as I could for patients with cancer. And then I joined the Royal Marsden in 2003 as a junior doctor to see if I really liked it or whether I could do this as a career. And then I got a training job there in 2004. And I'm afraid I've never left. So I did all my training there. I did my PhD at the Institute of Cancer Research. It was actually in breast cancer for what was breakthrough breast cancer then, which is now breast cancer now. And when it came to getting a consultant job, I actually felt that at that time, around 2010, 2011, that in my lifetime I could probably, or hopefully, do much more for women with ovarian cancer and other gynecological cancers because there'd been so much progress to date by then in breast cancer. And we were way behind, in my view, and I'm sure shared by others, in ovarian cancer. So that's how I changed and where I am today. So usually what happens, the majority of women with certain types of ovarian cancer may have a response to treatment, and then it's about follow-up. And that watching and waiting time, hopefully living your lives and surviving and getting on with things, attending follow-up. But for the majority of women, disease comes back. And then it's about having episodes of treatment and then time off treatment, and about survivorship during treatment and in between. But unfortunately, that time between episodes of treatment tends to decrease. And then that patients may well feel more unwell, and then we know what unfortunately happens to too many women in the end. But this is just a curve that is a trigger for me to say that despite women being diagnosed with advanced disease, we do see this tail end of the curve, around 20% of women that never relapse. So despite having advanced disease, why is that? We know a lot more compared to 10, 15 years ago. For example, we know more about the significance of having a BRCA mutation, and many of these women may be in that group. But also just for me to point out that despite having good treatment, good chemotherapy, good surgery, around 1 in 5 women's disease will come back within 6 months, which is far too soon. Around 55% or so will relapse more than 6 months later, 30% more than 12 months. And then from a researcher's point of view, from the clinician, as we talk to you, it's about why has that cancer become resistant to our attacking mechanisms, and how can we fool it again in order to achieve better control? So this is a little table, a graph really, that I put together more than 5 years ago with my predecessor, Professor Kay, that many of you may recall. And it's really outlining, we all say ovarian cancer, but we know that means fallopian tube and primary peritoneal cancer as well. But also within that, there are different subtypes of cancer. And I think that's really important to understand because they behave differently, they look different under the microscope, and the responses to treatments are different. And the reason for that is that because they are different. There are different molecules driving that cancer, why that cancer occurred, and why they may not be so amenable to attack with our standard treatments and even the more targeted treatments that we have. So I'll take a couple of moments of your time just highlighting some of the types. So with ovarian cancer, it's generally divided into epithelial and non-epithelial. The most common type of ovarian cancer, albeit rare as ovarian cancer is high-grade serous. And that's the type that is more associated with BRCA mutations and probably the one that you hear about the most. But I'd really like to focus your attention also to the rarer types of ovarian cancer. That's low-grade serous, mucinous, clear cell, and also endometrioid. With the non-epithelial, just a terminology, these are rarer types, but we see a fair amount of that, and certainly at the Marsden, which we call granulosa cell cancers, or other cancers called germ cell cancers, which generally affect younger women, also children with this type of disease. And the good news is that they're very chemoresponsive and there's high rates of cure. They're very rare cancers, but obviously a real problem as well. So I hope I've told you that ovarian cancer is not one disease, yet, frustratingly, it is generally treated the same, at least at diagnosis. You'll be familiar with carboplatin and paclitaxel. So I've told you how different these diseases may be and the responses to treatment, yet as it stands today, everyone gets carboplatin and paclitaxel. So the key point that I'd like to labour about the treatment of ovarian cancer is a multidisciplinary team. It's not just about the oncologist, it's about the surgical aspects, the radiologists, the pathologists, the intensive care team, the anaesthetists, the clinical nurse specialists, far too many to mention, but just to tell you that we all work closely together. It may not appear that way, but behind the scenes we certainly are. And with this disease, it's really important to be treated in a cancer centre because it's not a common disease compared to breast cancer or prostate cancer. And hence it's important to be linked into a cancer centre. The key principles, as I'm highlighting, is a multidisciplinary approach and linking in with palliative care as well as the primary care teams as well as the GPs. And the aim of initial treatment is to obtain complete remission, even in advanced disease, through a mixture of surgery and drug treatments. So I'm not going to talk about surgery because you're going to have a very eloquent speaker speaking after me, after lunch, but just to say that there are new techniques in surgery as well. And this is just some of the work that you may have heard about in the press and such. And this is the Royal Marsden team in the Royal Marsden magazine. There's a device called PlasmaJet, which is aimed at ablating disease that is so small, as you can see, these little studs of disease that are difficult to cut away, but actually by blasting them really may well be helpful. So we've certainly seen good results with this and reducing the length of stay of patients in hospital because of the complexity of cancer surgery. Just to mention, I mentioned to you briefly Avastin or Bevacizumab, and this was a real breakthrough in ovarian cancer, a number of headlines, and I wrote this article some time ago now with a question mark about whether this is going to be the new standard of care. We were all very excited about this drug, and I'm sure you recall access about this drug all over the world and also within the UK, and the discrepancies between England, Wales and Scotland, for example, and Ireland. But what were the results really? These are averages, and of course everyone's an individual. The time before cancer getting worse improved by a couple of months. That's the average. Clearly need to do much better in my view. But for a subgroup of women, the surviving with this disease was substantially better. And they're the patients that unfortunately generally the outcomes are worse. So with stage 4 disease or having cancer left behind after surgery. And that's where I think that's really meaningful with an around 8 months improvement in survival. But this was sufficient given the lack of more effective treatments that we had at the time to be EMA approved, so European approval, and available in England. I'm focusing on England here at this point via the Cancer Drugs Fund. I am going to mention something you may have heard about. There's been a lot of hype about it, and it's called HIPEC, and that is hypothermia and giving chemotherapy delivered into the peritoneum. Now, again, I'm sure Christina will talk or allude to that, but just to say that this it is a new option in trials and in research. It was published in the New England Journal of Medicine a year ago or so, and exactly like the editorial was at the time published by a group from Memorial Sloan Kettering in New York, Are We Getting Warmer? And that's exactly it. It's a step, it's a first step in my view, but it's not really changing standard of care yet. There were a number of potential criticisms of that study and where we could actually improve upon. I certainly don't think it should be dismissed, but we need to do a lot more work and research in this area. And there will be, hopefully, including our centre and others in the UK, really helping the international groups in developing a better trial to answer that question, whether HIPEC can be standard of care. So only 2 weeks ago, the new European Society of Medical Oncology and Society of Gynae-Oncologists, called ESMO and ESGO, published their guidelines to help clinicians and teams, all over the world to have some consistency about what's the consensus, what do specialists really feel. I was privileged to be part of that. And one of the key messages is that HIPEC is not standard of care universally, but there is a role for it to investigate more in research. So I hope I've convinced you that there still is an unmet need for patients with newly diagnosed ovarian cancer. Yes, surgery, chemotherapy, Avastin, but we need to do better. We need to improve not only overall survival, but quality of life, time before the next progression, time before the next chemotherapy, delaying the physical symptoms of ovarian cancer, which is associated with the disease getting worse. We also need to consider everyone as an individual. I've told you about the pathology and histological subtypes we need to take into consideration, but also molecular markers like BRCA, age, comorbidities. There are other things beyond cancer that may be having implications on the management. For example, if somebody has diabetes or kidney problems or other problems that may be making the treatment a challenge to deliver. We need to take that all into consideration, and that's what we do. There is an urgent need, and then I want to focus on a real success story that I'm very proud to have been part of. We presented this work at ESMO, one of the key global conferences, and the trial is called SOLO-1. We presented that in October 2018, and at the same time, same hour, published this in the New England Journal of Medicine, which is a very highly regarded journal beyond cancer. And this is an international trial, and there are many women that participated in the UK, and patients at the Royal Marsden were recruited as well, and we recruited the most patients in England. So just to tell you a bit about this trial, this was patients with newly diagnosed ovarian cancer, advanced disease, high-grade serous or endometrioid. Patients needed to have a BRCA mutation. So this is for women with BRCA mutations. They have an attempt at surgery and respond to chemotherapy. And then just to say, with high-grade serous ovarian cancer, the likelihood of responding upfront to chemotherapy is high compared to many other cancers. By that I mean 70 to 80%, so 7 or 8 out of 10 chance of benefiting from chemotherapy. And I think that's good. So those women that may have responded, usually they'd go on to follow-up. So that's the placebo arm in this trial. And what we did in this study was randomise patients. There was a chance of getting a drug called olaparib, which is a type of drug called a PARP inhibitor. I'll talk a little bit more about that, don't worry, but I just want to show you this trial. And the aim of this study was to see if we could improve the time before disease came back. And I'm just going to talk you through these results. I'm not sure how familiar you are with these type of curves, but this is what we see in clinical trials. And the take-home message, here at the bottom, you've got months since patients were entered into the trial. And then you've got percentage survival on the vertical axis. The further apart the curves, the better. If curves overlap, it means there's no difference compared to placebo as standard of care. Here, you see a massive separation of the curves, and they're continuing to separate. And this, around the world, was outstanding results. People didn't expect this magnitude of difference. And it was a real challenge for me to be quiet about this for a few months when I knew the result, and I had to be quiet till it was, and those of you that know me will know that's quite difficult. The message here is that in the standard of care placebo arm, at 3 years, 27% of women were progression-free. In the patients that received olaparib, over 60% of women were progression-free. We haven't seen that in ovarian cancer. We haven't seen that kind of benefit in gynae cancer. And even, in this meeting, it's not just about gynae cancer, it's all other cancers. People with other cancers and experts in that field thinking, wow, this is an amazing result. I know there's going to be lots of questions. I'm not going to dwell so much on more on this, but we can take questions. I just want to give you a flavour of some progress and some other progress throughout this talk. So the main thing is that this drug led to unprecedented, I do believe in that word here, improvements in time before cancer getting worse, on average at the moment of around 3 years benefit. There's FDA approval, so in the States was in December, so we presented this in October, and EMA approval, we heard 26th of April, there's a positive opinion, and this was NICE only a few days ago, so let's watch this space. So I've spoken to you again about the general course of women with advanced ovarian cancer. This is just a sort of pictorial view, if you like, of CA125s potentially going down very well for some time, then they go up, symptoms may occur, having episodes of treatment, and recurrent episodes of treatment, but that time's getting shorter and shorter. And one of the complications of this disease that I'm sure you're far too aware of is bowel obstruction, which is a very difficult condition to treat. So what about, I've talked to you a little bit about drugs, but I think we need to think about the whole picture. The impact not only on needing treatment, but the impact of recurrence on daily activities due to the physical and emotional problems associated with recurrent disease. And oncologists and the clinicians and nurses looking after you are much more aware of this. We heard you, we know that there are more problems, and in order to try and understand that more, there are now studies and publications looking at this in a bit more detail. And I want to tell you how important we really do take this, and very happy to get your views about how we can perhaps work together in the future about improving quality of life beyond treatments. Oops, right. So traditionally, you may know that ovarian cancer has been termed as platinum resistant, platinum refractory, partially platinum sensitive, very complex. I don't want you to think of your disease that way, okay? Because it's not as though the cancer wakes up at 6 months and thinks, I'm going to be resistant now, or I'm going to be sensitive to further carboplatin. It is a continuum. It is a guide for us to try and have some understanding about how likely further carboplatin or other treatments are going to work. But we realise how wedded not only patients but clinicians are to these definitions. And I've had a number of consultations where they say, well, Dr. Banerjee, my disease is platinum resistant. Why are you recommending carboplatin? You know, it's platinum resistant. And it's because platinum is a very good drug, and actually having more and more platinum, you can get further responses even in platinum resistant disease. And I show you this and say traditional because I'm very keen to let you know that this consensus that we had, which I'll talk about in a minute, has actually disbanded that terminology. Okay, I know it will take time to filter through to clinicians and researchers and such, but I hope it's a signal to you that platinum can be used well again. This is a host of drugs that can be used, paclitaxel, topotecan, gemcitabine, carboplatin in combination with these, hormonal therapy, which I'll talk about briefly, but also more, in the last 5 years or so, maintenance bevacizumab or PARP inhibitors. So there are a host of options, and it's really about what's the best option for the patient in front of me, for you, at the right time. And I always say there's often more than one option. I've just told you there's loads of options there, but it's that thinking about what my job is to do, to sort of how to best sequence and try and predict what may happen, and also dovetailing this in with the clinical trials and what may be on the horizon. And therefore, as many of you may know, there's eligibility criteria, and what I wouldn't want to do, and we can't always predict this, is give you a certain treatment or recommend a treatment which will then stop you going into a clinical trial which is relevant to you very shortly. It's impossible to predict that because trials come and go all the time. We can't predict how the cancer is going to be behaving. But that's what I try and do when I see you and others and recommend. So I've mentioned this consensus conference. There were 40 of us from around the world. I was pleased to see a number from England and UK. I'm somewhere in the grey over there. And this was published this month. I'm just going to focus on this slide because that's what's relevant for me to talk to you. And it's what I was saying, that this new definition about patients with recurrent ovarian cancer, it's a relatively simple algorithm so that doctors, oncologists, teams, nurses, yourselves can think about, well, where do I fit? I know it's not an algorithm that's 100% future-proof, but it's some signposting. So patients with recurrent ovarian cancer, we need to take into consideration a number of factors. Tumour biology, how is that cancer going to behave? The molecular profiling, prior responses to treatment. For some patients, paclitaxel doesn't work very well, but others, they work really well. And I would think about using it again and again. Must take into consideration persistent toxicities, allergies to chemotherapy, a challenge, symptoms, and importantly, your preference. For some women, they may be too unwell or thinking, you know what, I don't want to have any more treatment. And then it's about really working together as throughout the pathway of recurrent disease, working with the palliative care teams in the hospitals and the communities and the GPs. Surgery may well be an option in recurrent disease. I think it really needs to be considered. As you know, I'm not a surgeon, but I work in a multidisciplinary team and always consider for each patient with recurrent disease whether surgery may be helpful. And then with this red box, as I say, these new definitions, where platinum might be the best option. Re-challenging seems to be justified. And then we go down a pathway about symptoms, contraindications to certain drugs like Avastin. In this country, remember this is global, access in the NHS, we can't access, in England at least, Bevacizumab in recurrent disease. And then also thinking about PARP inhibitors. Is a PARP inhibitor best for the patient in front of me right now, or should it be Avastin? And then, when platinum might not be the best option for the patient in front of me, maybe there's early relapse, progression on prior platinum, and patients can't tolerate further platinum for one reason or another, for example, allergic reactions. So think of non-platinum therapy, and potentially with the addition of bevacizumab. Now, just to remind you, as I said, these are global recommendations, and therefore access to drugs is another factor. So this is an old slide, as you can see, 2001. This was from my dear colleague, Professor Gore, who many of you may know of or had the pleasure of meeting. He's the one that convinced me to change from cardiology to oncology. He interviewed me at the Marsden at the time and asked me a question. I was very young, in my early 20s, and he said, where do you see yourself in 10 years' time? I was like, I didn't know what to say, I must say, and I said, sitting in your chair, doing what you're doing, interviewing the next generation of oncologists. And I thought, oh, what have I said? And then he gave me the job, and there were 12 posts for junior doctors, and he gave me a job on his team doing gynae, so treating women with ovarian cancer. So that's how it all went full circle. Unfortunately, he passed away suddenly under unforeseen circumstances earlier this year. But we are, I'm continually learning from him, and it's a pleasure to see his work and go on with his legacy. So this is an old slide, but very important principles. Do we treat? When do we treat? When do we treat? When do we start treatment? How frustrating. Do we treat on a rising CA125? And my view, and I appreciate I was trained by him, but many have shared the same view, too early, just on a CA125. You're going to have, you've got no symptoms, there's nothing on a scan, and you're going to start cancer treatment. Intuitively, you think, well, treating early is going to help me. But actually, we've done studies, and ultimately the survival doesn't change. And it's about quality of life, survival, having time off treatment and on treatment. So, but if you leave it too late, when women are unwell from the cancer, they're not going to be well enough to handle the treatment or have time for the treatment to work. So it's really important about getting the right time. And this recurrent ovarian cancer equals, as I said in the beginning, for the majority of patients, unfortunately, incurable cancer, and the terminology of palliative chemotherapy or palliative treatment. But I've added this bit, this red box, because I believe it's changing times. We've got improved therapies, there's more options, and there certainly is longer survival. When I joined Professor Gore's team in 2003, my conversations were about carboplatin, paclitaxel, and an excellent drug called Calyx. And that was about it. And now, we have many more options, and as patients under my care will know, lengthy consultations and waits, because we've got so much to talk about now, which is good. Okay. I am mentioning bevacizumab because I do think it's a useful drug for many patients with recurrent disease. And this was for patients with the so-called, as I told you, platinum-resistant disease. So by that I mean when cancers got worse within 6 months from the last platinum. And in this trial, patients had less than 2 prior cancer regimens. And importantly, no history of bowel obstruction, no risk of bowel obstruction, because bevacizumab, one of the problems with it attacks blood vessels that feed cancer, and that means that there is a higher risk of bowel perforation, which is very serious, can be a fatal event in itself, and also something called fistulation, which is an abnormal communication between the cancer and areas you don't want it to communicate with, like the bowel or the bladder, for example. So it's really important about selecting the right patients for the right therapy. And platinum-resistant disease, these are averages, and I appreciate there are many patients in the room where it's worked out much better. But generally, response rates then, despite the 70 to 80% I said to you in the beginning, goes down 30, 40% perhaps with paclitaxel, going down with some, future lines of treatment 10 to 15% or less than 10%. That doesn't mean that for the individual woman in front of me it's not a good option, but it's important to understand the averages when you're going through treatment. So why was bevacizumab such progress leading to the license in Europe? Was because the response rates were improved substantially. The progression-free survival, there was a 52% improvement before the cancer got worse for women that had chemotherapy with bevacizumab compared to chemotherapy alone. Improvements in patient-reported outcomes, what you've been saying to us about symptoms. There was more than 15% improvement in gastrointestinal abdominal discomfort by 8 weeks. And I appreciate this is what we call a subgroup analysis, but important signals that overall survival, so living, basically being alive with cancer, with patients in the paclitaxel group, if bevacizumab was added, that improved from 13 months to over 20 months. Okay, so I think there's a good signal there. So what about other options? So we're on weekly Taxol, we use that a lot. There are a number of other combinations that have been tested over the years. I was involved in many of these studies, but unfortunately, for example, we published last year on lincitinib. This was an insulin growth factor inhibitor targeting the glucose pathway that you've heard a lot about, insulin and glucose. And we had high hopes, but it didn't work out. And I think it's important that we've learned a lot from these clinical trials. I must say, I've had individual patients that have done very well on this treatment, but it's about the overall picture in order to go to licensing and such. And so you may have heard in the press last year, there was a drug called vistusertib that was a phase 1 trial that was led by our centre that looked very encouraging, response rates of over 50%, and delaying time before cancer got worse by 5 months or so. Got to labour, these are all, I appreciate what the press reports, about potential promising agents, but they're very early phase clinical trials, and we need to do more clinical trials in what we call randomised fashion, which means comparing it to standard of care. Because I've been part of a number of trials, I think this is excellent, I want this license, I can see my patient benefiting from this. Then we do the bigger trials overall that hasn't come through. But that's what I always try and think about targeting the right patient for the right treatment. So Octopus is a national trial that I've been leading. It's been open across the country in more than 14 centres, and that's looking at adding new agents in platinum-resistant ovarian cancer with weekly Taxol. The first arm, it's called Octopus because we hope to have many arms, and the first arm was vistusertib, the one that was reported positively in phase 1 last year. We've submitted the results to ESMO, so let's see. I know many of you may know people or be in here that was on that study. The DICE trial is ongoing, again nationally, you may be familiar with that. And both these trials are targeting a pathway called basically the PI3 kinase or TORC1, TORC2 pathway. So hormonal therapy, I do want to spend a few seconds on this because I think it's very important. By that I mean anti-estrogen therapy. So we use that a lot in breast cancer, as you may be familiar with. But I often recommend letrozole or tamoxifen for the right patient in front of me at the right time. I appreciate it's not licensed for this, but often we do things that aren't licensed because we're not going to get a massive trial on this. So we looked at our patients at the Royal Marsden, patients on tamoxifen, on letrozole with high-grade ovarian cancer, nearly 100 patients, 60% were platinum resistant, and the response rate was just over 10%. We didn't really see a difference whether it's tamoxifen or letrozole. It's an option when chemotherapy may not be an option, but you'd like to have more treatment, patients would like to have more treatment, and you're well enough for treatment because the side effects of this are very different to chemotherapy. And and also response, but I really want to labour the point that holding disease stabilisation, if we can hold the current situation for as long as possible, I think that can be more meaningful for many patients than getting dramatic shrinkage suddenly and then it stops working a month later. So we need to balance these things. I'm not going to dwell too much on that, but just to say that this study effectively showed that, yes, chemotherapy may be better than these hormonal treatments, but patients experience more side effects and a poorer quality of life compared with actually being on hormonal anti-estrogen treatment. So we need to balance all these things. So I led a study of actually Abiraterone. You may have heard of this drug, revolutionised prostate cancer, and I wanted to see if I could harness that potential in ovarian cancer. So it's targeting a receptor called androgen receptor. We overall, this trial didn't show a significant response rate to take it forward, but we need to focus on individual patients. One of my patients had a good response. She had low-grade serous ovarian cancer, a disease that is known not to be responsive so well to chemotherapy compared to some other types. 11 patients had holding disease. 4 patients was more than 24 weeks of holding disease. And 1 patient remained on treatment with ongoing clinical benefit. Again, this lady had low-grade serous disease. And after being on this drug for 82 weeks, had a response. Okay, so that's that. I'm going to spend some more minutes on BRCA and PARP inhibitors because those of you that know me is that I'm really taken by this target because I think it really makes meaningful difference for women with this disease. So I've mentioned to you the first-line trial SOLO-1, and that's of the PARP inhibitor olaparib. And I'm not going to give you a whole history lesson on PARP inhibitors, but I'm going to give you some examples of the rationale for these practice-changing studies. And it actually goes way back in 2005, and this was published in Nature from the Institute of Cancer Research, where I was actually in the labs at the time. And I thought, oh, this is all in the labs, why can't this get to my patients? But that's where it all started. That's why we need investment in research and lab research and linking in with clinicians to take these forward. Then led to the phase 1 study, which is there. And that's where we could really see a difference. We're treating patients like yourselves. And women were saying to us, this is different. This is not like chemotherapy. It's working. And I feel good on it. And there are patients that have been on these treatments for many years. And remember, in these trials, in those days, patients had no other options. They'd exhausted conventional lines, and then they were going to phase 1 studies. Now, phase 1 trials have changed a lot since then, because often we send patients earlier on to phase 1 trials. So please don't come away thinking phase 1 trials are, okay, there's no other option for me, I'm going for completely experimental treatment. The whole paradigm has changed, that actually to access some targeted treatments, we're sending patients earlier to early phase trials and then reserving chemotherapy for some patients slightly later. So we could see these amazing responses. Everything under that 0 line is a response, so shrinkage, and you can see more shrinkage, increasing tumour shrinkage compared to women that don't have shrinkage. And of note, some of these women had platinum refractory disease. Carboplatin was not working for them, the cancer was getting worse. What we do know, what we've known for some time now, is that beyond BRCA mutations, around 50% of women with high-grade serous ovarian cancer, they also could benefit potentially from this approach. We know this now, but at that point it was all theoretical. Because there are other genes and other molecular markers that may make your cancer more vulnerable to this type of attack. This type of attack is called synthetic lethality, okay? And this is more a trigger for me to tell you that PARP inhibitors are effective, and we now know that, they're licensed for women beyond BRCA mutations, women that don't have BRCA mutations. But just to say that patients with BRCA mutations, the drugs tend to work better, okay? They do, we know that, so it's a predictor of PARP inhibitor sensitivity. PARP inhibitors are approved in ovarian cancer. Now, over the last couple of years, for example, olaparib is now licensed, and so EMA approval and also FDA, regardless of BRCA status. Same with niraparib and also rucaparib, but also rucaparib is given as a treatment rather than a maintenance therapy. So what do I mean by that? So a few minutes. Again, very privileged to be part of this practice-changing international study called SOLO-2. And here in relapse disease, women with BRCA mutations and platinum-sensitive relapse disease were randomized after they responded to chemotherapy, where normally they wouldn't be on anything. It's it's placebo, or what we call maintenance treatment. So you finished your chemo, you've had a response, now we're going to see if we can hold where things are or also get even more shrinkage. And again, as I told you, look, these curves are very far apart. And there was a 70% improvement in the time before disease progression. What does that mean in real terms? These are averages again, but for the majority of us, the average time before cancer getting worse was 5 months after chemotherapy for women, whereas those on olaparib, it was 19 months. So that's meaningful. But I have the caveat, is what is it at what cost? By that I mean to quality of life and side effects, okay? We now know, or we've known for quite some time, that the side effects tend to be worse in the first couple of months, and then they tend to get better. And it's really about supporting patients very well whilst they're on PARP inhibitors. By that I mean thinking about potential nausea, vomiting or diarrhea, or indeed general fatigue or just feeling lightheaded or fuzzy-headed that some of my patients talk about, okay? These are generally what we call low grade, so not severe enough to stop treatment or need to be in hospital, but still meaningful, especially if you're going to be on these treatments for quite some time. So it's not just about olaparib. Olaparib was the first PARP inhibitor to be licensed and approved. Now we have the luxury of a choice, so niraparib, and I just want to highlight again the importance of quality of life on these treatments, and we published the quality of life in Lancet Oncology last year. I'm leading a study that I hope that many of you and your colleagues and friends will be part of, called Monitor UK. And that's about you. It's about the real world experience of patients on the PARP inhibitor niraparib. So we want to learn from you what you're really feeling about side effects, quality of life, because sometimes it can look all rosy in a clinical trial, but these are really highly selected patients going into clinical trials, and then they're approved in everybody, and not everybody is the same as the kind of patient in a clinical trial in terms of fitness, energy levels, other diseases. So I really want to capture what's really happening so that we can work towards improving this. So I hope this will open in the summer, and this will be across the country. Rucaparib, just to say, it's a treatment as well, and it's available for patients who have had at least 2 prior chemotherapies, BRCA mutations. The response rates were over 50%, and there's European approval. This is just to show you about progress. I know it appears a long time, but actually this is relatively quick in drug development. 2005, I showed you the preclinical work. Then 2014, olaparib, and then all these different indications: olaparib, rucaparib, niraparib, EMA approval, FDA approval, BRCA mutations, patients with BRCA mutations only, and then regardless of BRCA mutations, maintenance therapy, and then treatment. There is real progress, and now we're in the first line setting. So thank you also to all of you and your peers and your colleagues for actually being part of many of the clinical trials that lead to practice changes. So access, what about access? So it's different in different areas. In England, for example, and this changes from, it seems, week to week. First line maintenance olaparib, how do you get it? Well, AstraZeneca have an expanded access program that's currently still open. There's the Cancer Drugs Funds for niraparib. There's a rucaparib access program if patients can't get niraparib for one reason or another, as maintenance or indeed as treatment. So what's next, and what's the real problems? I've spoken how great PARP inhibitors are, but I'm afraid I have patients that PARP inhibitors stop working at some point, okay? And this is where a lot of my research going forward and emphasis is going to be focused on, which is how to treat patients following a PARP inhibitor resistance. So way back, we looked at response rates, patients that have had olaparib, for example, in the past, and their patients do respond to chemotherapy afterwards. We also don't know why is one patient resistant to a PARP inhibitor, the other one isn't. So we need to learn a lot more from you. And we've identified where the BRCA mutation reverts on itself and therefore bypasses the mechanism of attack from PARP inhibitors. And we're now able to measure that not only in tumour biopsies, but in blood samples, what we call circulating DNA. So what about clinical trials for women whose disease have got worse on PARP inhibitors? There's the OREO trial, which is looking at olaparib as maintenance therapy again, as re-challenging with olaparib once patients have responded to further chemotherapy. And there's another study which I'm privileged to be leading internationally. It's the global study, which is looking at a completely new treatment. So it's called an ATR inhibitor in combination with immunotherapy and carboplatin for women whose disease got worse on a PARP inhibitor. So that's open currently at the Marsden, and it's opening across the country, and it's open in the States and Belgium and Spain will be. So BRCA testing. So we know that Angelina Jolie did a lot for us by raising the profile of BRCA testing, as unfortunately her mother passed away from ovarian cancer. BRCA testing is really, really important. I've had, when I lecture internationally, some countries say, well, why should we do BRCA testing? Because we can access PARP inhibitors irrespective of women having a BRCA mutation. And I'm like, it's not just about access, it's about the likelihood of responding to the treatment, but also let's not forget relatives. And if we truly are going to prevent this disease from happening, we need to identify women at risk who may well be our family members, and then institute prevention mechanisms and institute screening. The traditional pathway is referral to genetics. Sometimes it can take many months. Used to take up to a year for many people to get a BRCA result. That's all been sped up, and we sort of saw at the Royal Marsden and ICR that this was going to be a problem, you know, in around this time. So my MD fellow, Dr. Angela George, is a consultant colleague with me at the Royal Marsden. We did this pilot of over 200 patients at the Royal Marsden where oncologists like myself and the nurses on my team actually talked to you about BRCA testing, about the need for it. We got your consent for the test and then handed over to the geneticist to do the actual testing and then talk to you about the results. The turnaround time was 4 weeks, okay, for the results. I know that's different across the country, but things are improving. What about other novel treatments, just to end on? Low-grade serous ovarian cancer, I've mentioned that a few times, not so responsive to chemotherapy compared to other types. I talked to you about hormonal therapy as an approach. That's anti-estrogen therapy in this disease. Also, this is just to show you, this was a paper of, and this was actually my patient in the red with ovarian cancer that they mentioned there. This is for this drug, this treatment, vemurafenib, was for patients with a BRAF mutation, and this lady had a response, a shrinkage of over 60% for over a year. The new class to look out for of drugs in and out of trials, or in trials, hopefully we'll get them licensed at some point, is a class of drugs called MEK inhibitors, and there are a number of trials that will report this year or next. You may have heard of the alpha folate receptor. This is another targeted approach that we can try and fool the cancer. A drug called Bevacizumab has been showing some promise, either alone or in combination. And the Forward 1 trial was running internationally in the UK and it's close to recruitment. And we have submitted the results for ESMO this year. You may also have heard about the folate receptor because this was in the press a few years ago. It's funny what the press pick up on, but this was a very early phase trial that we were part of, led by the Institute of Cancer Research and the Royal Marsden teams. That's one of the headlines. It's amazing the way they say this, but I really think you need to take things with caution about what you read as well. Susanna Banerjee, my colleague who's not related to me, we're very good friends and colleagues. We did a phase 1 study in high-grade serous ovarian cancer. What we know is that if women have high alpha folate receptor levels in their tumour, they may be more likely to benefit from this treatment. There is an expansion going on currently in high-grade serous ovarian cancer, and I'm pleased to say that the plan is for an international trial, obviously with the UK as well, and I'll be leading that, so it's definitely going to be in the UK as well. What about immunotherapy? I've gone so far without mentioning immunotherapy. Well, the reason for that is there's a lot of hype about immunotherapy, and it's worked really well in some cancers, and including in some gynecological cancers, for example, in endometrial cancer for certain types of molecular abnormalities. But I think I wouldn't be the first to say that it's been relatively disappointing so far in ovarian cancer overall. So when we were all excited, but you look at these response rates, 11%, 14%. Well, if I was being sort of critical, well, I've told you in hormonal therapy with tamoxifen and letrozole, it was much the same. But, so why are we so excited about this? Because for patients, if you were one of those patients that had a response, so for example, here with ovarian cancer, platinum-resistant disease, there were 2 complete responses. By that I mean disease disappeared. And for women where they may get a response, they're much more durable than what we've seen with chemotherapy, for example. So we need to select, and how do we know which woman is going to benefit from immunotherapy? The truth of the matter is we don't know just now. There are some signals, PD-L1 expression, certain mutations, microsatellite instability, something called Lynch syndrome, for example. So the Javelin 200 trial, that was a phase 3 study of immunotherapy with or without chemotherapy, was presented in Hawaii in March. Very disappointing, I'd say, for the community, really, that actually immunotherapy alone or in combination with chemotherapy was no better than Calyx alone. And the Javelin 100 trial, which was first-line treatment, there was a press release that said, we're terminating this study now. It didn't meet the criteria to continue. So disappointing. So is that the end of immunotherapy in ovarian cancer? I don't think so. But we need to think about more clever combinations. How about non-chemotherapy options? So immunotherapy with anti-angiogenics like bevacizumab, or indeed PARP inhibitors. And actually, I think this, I appreciate isn't published yet, but was presented last year in ESMO. Very interesting signal with bevacizumab and nivolumab, so immunotherapy and bevacizumab, that actually confirmed response rates was in the order of almost 30%, and they were durable in some patients. So this is a study that I'm currently leading called EORTC 1508. It's an academic study of European collaborations, and it's been led by the Lausanne group. George Koukos, who you may know or heard of, has done a lot in immunology in ovarian cancer, and we've teamed up together to lead this study. Now, this study is open in many countries in Europe. In the UK, it's only been open at the Royal Marsden to date, and so patients from all over are coming to access this treatment, and it's about, hopefully, to open at Guy's and St Thomas's as well. So this is looking at Avastin, so bevacizumab with immunotherapy, and actually aspirin, and seeing about the aspirin anti-cancer effects as well. We urgently need to finish this study because, as I say, it's an academic study and funding is limited, and so it will close one way or another in December. So hopefully we will be able to get a valuable answer. So in the last few minutes, I want to focus on some further unmet needs. There are a lot of studies in high-grade serous ovarian cancer. Understandably, it's the most common type of ovarian cancer. But I see patients with much rarer gynecological cancers, and some of you are here today, for example, low-grade serous or clear cell carcinoma. And many trials exclude women with these types of diseases in those trials. And it's really tricky and challenging to find out what's the best treatment for women with these diseases, because trials haven't focused on that disease type. For a variety of reasons, the rarity, the need of international collaborations, and funding for these studies, because 1 or 2 patients in one country, you're not going to get an answer. So we need to work together. I very much hope, it's been keeping me awake for about 3 years, trying to get funding for this and get this open. And this is the first trial directing targeted therapy up front, and it's based on a mutation called ARID1A. And that's more common in women with clear cell carcinomas, and there have been some with endometrioid cancer and carcinosarcoma. This is an academic collaboration led by myself and at the Institute of Cancer Research and the Marsden, and we're working together, as you can see, with the Gynae Cancer Intergroup, ENGOT, the European collaboration, my friends in Canada, and also in France. So we can't open all around the world because we don't have the money. But you know, France, UK, and Canada will be opening, and I hope it opens at the end of this summer. Another unmet need, very close to my heart, is improving outcomes in older women, because ovarian cancer can affect any patients in any age. But we do know that the rates of ovarian cancer rise with age. And we are living longer, and we're living well longer. So, you know, being grandparents, being active, actually working later, you know, we need to be well enough, and there needs to be more work, I think, in improving outcomes in older women. So my MD student has been working very hard with me about how can we not undertreat older women, or how can we influence people not undertreating older women, but also on the other side, not overtreating older women, because our biological reserve as we get older is going to go down. And so Dr. Duma, as a collaboration, we've been working together on really trying to learn more about how we can predict more side effects or toxicities, and how patients will respond to treatment when they're older. When I say older, I mean over 65, yeah, or 70. So we have a study that will be opening hopefully this year, which has been supported by Wellbeing of Women, and it's looking at the feasibility of implementing a frailty assessment for women over the age of 70 in clinics by oncologists and the allied healthcare professionals, so that we can really tailor and make the teams actually think a bit closely about addressing some aspects that may help women get through treatment more. For example, polypharmacy, addressing comorbidities, mobility, other aspects. And we'll be looking at something called sarcopenia, which is muscle mass that we can look at on the CT to predict survival. So to summarize, anti-angiogenic agents targeting blood vessels like bevacizumab, PARP inhibitors have shown success so far. It's not the end of it. I'm not going to give up there. There's lots of other approaches that are aimed at reversing drug resistance, and immunotherapy is being tested. The key point and the key message is selecting patients using robust biomarkers will be the key to success, to define subpopulations for specific therapies with the greatest chance of benefit. So this is some of the members of the Royal Marsden Gynecology Unit. We work very much as a team. We're very close, and we work not only at the Royal Marsden, but obviously we're collaborating and sharing best practice across the UK and also internationally. So I lead the research team, as well as obviously treating patients in clinic. And our mission is simple, basically to save the lives of women with cancer, developing better treatments, more long-term remissions and quality of life, and having more women cured. So, as I said, I work at the ICR, I have collaborations with the ICR2. Here are some of the faces, because sometimes you don't see them because they're in the lab. And so there's Dr. Natrogen, Professor Lord. He was instrumental in that original PARP inhibitor publication in 2005 that led to all this. And so it's great to be working with him, and it's his work that has triggered me for that Atari trial in clear cell carcinoma, seeing the implications or potential vulnerability of these cancers to ATR inhibitors. Susanna Banerjee, my colleague, and Professor Downs, and as you may have seen only in the press the other day, there was a spread about the Institute of Cancer Research focusing on breakthrough treatments to target drug resistance. And don't worry, ovarian cancer is certainly going to be in there. So we have a number of projects just talking about drug resistance, number of clinical trials. We always have clinical trials open, and I'm evaluating which ones will be best for our patients, from early phase 1, all the way to phase 3, either on the gynae unit or the drug development unit. national and international trials. We do recruit a lot of patients to clinical trials, as you know, because this is what we specialise in. And I really appreciate and recognise the effort it is to travel from far away to centres offering trials. We do accept referrals for trials from all over the UK. I have a couple of patients being treated from Scotland and also from Wales in clinical trials. So thank you. I very much hope I can help improve the lives of women with gynecological cancers. You may recognise some of my team and my patients even in the room today on World Ovarian Cancer Day, and also the Lady Garden fundraising group have helped raise funds for clinical fellows on my team and some of my research so that we can deliver clinical trials. So thank you very much.